Hi, everyone, and welcome to our 81st virtual shadowing session. My name is Taylor, and tonight we have a session titled Insight on a Career in Medicine and the Administrative Side of Medicine with Dr. Compton Broders. As always, we have our working group, which is comprised of all of our members on the left, and our four physicians, Dr. Fowler, Dr. Salazar, and Dr. Marchetti and Dr. Reno. Stay tuned because next week we're going to have a specialty spotlight in PM&R, followed by a session on cardiology, and then we're going to take 2 weeks off for the holidays. So enjoy yourself during that time. Just to remind everyone, we're going to have a Q&A at the middle and end of the session. So be sure to put your questions in the chat as you go along so we can get those answered for you. And also, save all the questions about the quiz till the very end because we're going to provide you with the QR, and we're also going to give you a link for session 3 quiz link so you can redo that or go back and do it if you didn't in the past. And that being said, I'm going to let Dr. Fowler introduce our guest.
Well, welcome everybody. It's so nice to see all of you back, all 150 that we have already online with us. It's so good to have you. This is our 81st session. We can't believe it's gone this far for so long. We've got 80 lectures up on the virtual shadowing website there for you to use. And we've had over 500,000 viewings of the sites of the lectures. So clearly this is helpful to you. As many of you heard me say over the many months, I'm on the admissions committee at UT Southwestern Medical School, and we are definitely accepting and acknowledging virtual shadowing hours as people apply to medical school. I'm actually seeing a rather interesting thing is that we now break down shadowing in 2 ways, in person and online, or in person and virtual. So I just want to encourage you, please come to these talks. We have a remarkable individual tonight whom I'll introduce in just a moment. And we've got some stars coming up soon. Dr. Ben Wynn is going to be with us also on the admissions committee next week. Ben is a PM&R, physical medicine and rehab doc, and he's on the admissions committee with me. And he helped us, as some of you may remember, with our online practice interviews, which was really a cool thing. And then Dr. Laura Collins, cardiologist, is coming the week after that. Laura is also on the admissions committee with me and is a marvelous individual. So we're gonna be here as long as you keep coming back. So we're booked out into March now for our lectures. And to try to give you a little teaser to encourage you to come, we are going to open previous talks exams, but we're going to do it this way. We're going to take a handful of the talks, write exams for them, and then we're going to give you the link at the virtual shadowing talk on Tuesday night. So you got to come hear it to be able to get the link to one of our previous talks to get the exams where you can then print a certificate. We haven't done it yet. We're not done with it. We'll try to get it done in the next week or 2, or perhaps the first of the year. But we listened to what you said in the last few weeks, and we know that this was important for you, and we want to try to help you in your applications for your healthcare career. Now let's turn to tonight's speaker. I've been practicing medicine 44 years, all emergency medicine. I started in 1978. I was the first career person in the private sector running ERs for the Hospital Corporation of America. And then I retired and decided to do something nice and quiet. So I came to Parkland Hospital in downtown Dallas. And lo and behold, 21 years ago when I got here, there was this quiet fellow with his short graying haircut that I got to know named Compton Broders. Compton is one of the finest physicians I have ever had the pleasure to know. You're going to hear about where he trained and how he got so damn smart. But Compton was always the guy in the hundreds of hours that I worked side by side in this massive emergency department called Parkland. He was always the go-to person that if I didn't know what was going on, I would go see Compton. And Compton might not exactly know the answer. And he would say, he would always pull his glasses off like this. And then he would say, I don't know what the answer is, but this is the next thing I want to know. And the clarity that this always gave me was so remarkable. I became such a better doctor. Ladies and gentlemen, I want to introduce you to one of the most outstanding clinicians, friends, colleagues, sponsor of virtual shadowing. He is actually, the fact that we are here is in part because Dr. Broders has donated money to help us be able to be online. So that for so many reasons, I want you to join me, and please put it in chat. Welcome, Dr. Broders. Compton, you can glance at chat for just, put it in chat, folks. Welcome, Dr. Broders. So we can welcome our new friend joining us at virtual shadowing, Dr. Compton Broders. Compton, welcome. So glad to have you here.
Thank
And
you.
Look at chat really quickly. All the thank yous are popping in there. So there you are.
Well, this is somewhat intimidating, but I have, I have completed a career in medicine. I have been where you are, and I have traveled the journey, and my journey is over. And so right now I reflect on that journey and what I learned and what I didn't learn, and mistakes I made. And I want, and I would like you to learn from those mistakes, because I think that medical students now are better than we were 50 years ago. And so there is progress being made, although it's sometimes hard to figure that out. And so next slide. When I went to medical school, in order to get into medical school, you had to have good grades and a great MCAT score. As a result of that, we had some psychopaths in medical school, people who had no emotional intelligence. That was not even a term. And right now, fortunately, medical schools are recognizing that the inadequacy of grades and MCAT score. And I think that the third thing that you have to know is medical schools are asking, what kind of person are you? And this creates a dynamic of where you really are on a quest to know yourself. And I think that people who do know themselves make better medical students. And so you can have the grades and the MCAT score and not get in. Unfortunately, I think that the reverse is not exactly true. You can not have the grades and not have the MCAT score and be a fabulous person and not get in. So there is some work to do.
Compton, I would comment about that to say, we're still seeing in our application pool, we've had now over a dozen meetings this year, and we're still seeing applicants in our pool with the 395s and the MCATs and the 522s who don't interview well. And just in looking at that person, that it's not just the grades and the MCAT score, it's who you are.
Yeah, I think that one of the things that you have to have people ask, this is for the high school students, and the high school students to say, where should I go? And a doctor friend of mine, Dr. Lawrence Hum, said a really wise thing. Is it said you should go to the best college you can, and that allows you to make a 3.8. You don't. The corollary. I talked to some. I read an article about MIT, and the thing they make the most are tax attorneys, because they go there, science and all that stuff, and they're not very good at MIT, which means they're really good maybe at Maryland or UTNA. And so I think that you need to go to the best school that you can and to be able to get a 3.8. And so I think that, but developing yourself is one of the things that I've observed that is something you should do. And next slide.
Compton, when I was a kid applying to medical school at the age of 19 and 20, 19 was when I was applying. if you would have really asked me what my long-term motivations in this or that were, I couldn't have expressed them. We're asking for a level of maturity today for applicants to medical school and to all healthcare professions of folks that are able to show a lot of things, including the fact that they are stable psychologically. I mean, those who've been coming back to these programs, Compton, have heard me say time and again, for God's sake, don't get a DUI. You're going to have to put that on an application one day, and it's going to be a real problem for you. But please go ahead.
Yeah,
So
I think.
you didn't learn Spanish. Huh?
Well, I could have. I almost learned it, but
Did
I
you
did.
ever wish you had it at Parkland, since half our patients speak no English?
I took 2 months of Spanish in Mexico. I wish I had taken 4. And that 2 months helped me. I used that maybe every 10 minutes, or maybe every 5 minutes. So I didn't learn Spanish. I could have, I should have. I think that in Texas, I'm looking for, well, I've had this discussion with Dr. Salazar, and, I think that by 2030, it was going to be a requirement. So like if you're in high school right now and taking Latin, don't take Spanish. I think right now people can still get by without being bilingual, but I think at some point in time, medical schools are gonna make it mandatory, because it's the United States is a bilingual country, and that's just the way it is. Another thing that modern psychology didn't exist when I went to college. It was, Freud and Jung, and basically it was all BS. It was all philosophy, and modern psychology is typified by being empirical. So modern psychology is really pretty cool, I think. Modern leadership principles were in its infancy. I think right now, what you do when you're a leader or a follower, there are some things that are, this is what you should do. And there are some things you should not do. And so next slide. One of the things that I regret is never being a server in a restaurant. I think that is a giant lesson in listening. You have to listen very well, and it teaches people how to listen, and teach people who you learn about people in a restaurant. So servers, I think, is, being a server in a restaurant is really useful. Scribes weren't invented. I think everybody needs to be a scribe at some point in time, because you get to see up close and personal the thought processes of the doctors. A little bit is I was part of a group that started scribes in the middle 90s. And the things that we've observed from the scribe program is that the scribe program did not help the students get into medical school. However, it helped them get a residency, because when they hit the wards and they started clinical medicine, they actually were way ahead of the game. So they did very well in step 2. And so it really does help. And in watching scribes become doctors and become attendings, you find out that they learn their medicine as a scribe. They learn how they handle things, their approach to patients as a scribe, and it was pretty nice. So it's maybe, I think one of the professors at Southwestern did a study about what did it help you get into medical school. And it was it suggested it didn't. However, it did help get residencies. I never played a team sport. I was I was the smallest guy in my high school class. And consequently never played a team sport. And I think being on a team and learning about teams is real important, since medicine is a team sport right now.
And Compton, in the admissions process, we ask lots of questions about team activities, about being part of something larger, and how you work together as a group to carry out a larger mission.
Well, I think that another thing that I didn't do is that there was, at the time, there was not an emphasis on PE. PE was how you developed your body, and really physical education is critically connected to mental health. And so, somebody, the most uncoordinated person, really benefits from that. And so a dedication to having a physically fit life gives you increased mental strength. And that was really showed in a book that we get to later, and it's on combat. And it talks about how handling mental illness. And there was even a study where they looked at physical exercise versus Zoloft, I think. And it was the same. So your physical health, developing a pattern about that is good for your mental health, even if you're interested in just the mental part. Anyway, next slide. Also, one thing I have discovered is that in era of COVID, you think about scientific thinking or non-scientific thinking. And the thing about scientific thinking and scientific endeavor is science is wrong most of the time. However, non-scientific thinking is wrong almost all the time. There's a book called Wrong, which is a discussion about that, and the conclusion of the book is that 1/3 of what is written in medicine, it proves to be correct. So 2/3 are wrong, and that really depressed me. That really depressed me until I thought about how often prior to scientific thinking, in medicine, scientific thinking is really fairly new. It's maybe 100 years old.
Yeah, something like that.
Yeah, but it's not very. But scientific thinking, statistical thinking, is not normal for humans. We don't think statistically. We think anecdotally. We make decisions on anecdotes. I knew somebody who was vaccinated and was dropped dead the next day. Well, were they related? Probably not. But also, I have seen things come and go and be absolutely the cat's meow, and they prove to be wrong. And I think that the lesson to learn from that is not to trust science, but to be skeptical, have a skeptical approach to things. Look at things, look at data, read the fine print, and here are all the things that prove to be wrong. Notably, when I started, we chased premature ventricular contractions all the time. We admitted people, we gave them drugs, and it was all wrong. The story of advanced cardiac life support is a story of every 5 years, another treatment is shown to be wrong or harmful. Treatment of mild hypertension in the emergency department. At one point in time, we treated a person with a blood pressure, asymptomatic with a blood pressure of 180 over 120, with all sorts of drugs, poisoned them, and estrogens in women. Long time, your estrogen went away when you're menopause, and we put people on them, and it was harmful. So that there is a long history of the wrong thing. That doesn't mean.
Compton, I was just reading today about fluoride in water. There is no argument that fluoride makes teeth stronger, but they're also in utero, during pregnancy, exposure may affect children's IQ. there are two large scientific studies that have examined this. So, as you say, be skeptical of science.
Well, I think that you know it doesn't it's very uncomfortable for people to be unsure. We don't know. Humans don't like that term, and some humans really don't like it, and they're susceptible to all sorts of charlatans. And you have to like find your sources of truth, and at some point in time you have to believe. However, scientific thinking is correct. You know, I read a book called Uncommon Sense, and it was how scientific thinking was invented in Greece, and logical thinking, and it was not anywhere else. And so there is, but believing in science, and also science has all the warts of regular humans. There's jealousy, and there's backbiting, and there's lying, but in total, it is really fabulous, and it has helped things that were uncurable when I started medicine became curable. And I still remember a nurse that I knew went to get a physical, and she turned out to have Hodgkin's disease. It was an insurance physical, and they gave her the insurance. And like when I started, there was a resident who died of Hodgkin's disease when I was a resident. And it was kind of like, wow, that's just incredible. They gave her the insurance because the treatments had been so good. So there's been a tremendous advance in medicine. People say, what era would you rather live in now?
Right now.
Right.
Compton, when you and I are the same age, and we both started college at the same time. When you and I started medical school, Hodgkin's disease and Harrison's Principles of Internal Medicine, 6th edition, was defined as a fatal disease of the immune system. Yeah. It is now your go-to lymphoma. If you had to pick a lymphoma, pick Hodgkin's disease, because it is the most treatable. So without, and Compton, if I can blurt in one more thing. In 1973, when I started medical school, I was handed a famous medical journal article from Scientific American on the discovery of the trilaminar cell membrane. The cell membrane had only just been described. Fast forward a half century, and it is astonishing what has occurred. Moderna making a freaking mRNA vaccine based upon years of research in a matter of months to spread all the way around the world. Like you say, if you're going to live in a time, right now is the time.
Yep. Next slide. Things that I did right. Well, I took typing in high school, and I learned to type. I'm kind of a spaz. I didn't learn to type very well, but I did learn to type. I did some things which allowed me to be exposed to people of all types, and that was really good. I worked as a line worker at a desk factory. I was absolutely horrible at it, but I learned to really appreciate the people who did that. I went to public school. There was all socioeconomic types. There was not all racial types. It was not. However, again, it's a lesson in humility. I worked as an orderly. An orderly is kind of there is no such thing as an orderly now, but it was kind of a sort of uneducated scut person. And I remember I was tasked with giving a gentleman an enema at the Santa Fe Hospital in Temple, and the enema bag broke. It was a mess. It was an absolute mess. And I'm struggling to keep this clean but it was, again, it taught me the value of their work. and how hard it was. I was also, I got to work in my grandfather's lab. And my grandfather was a famous pathologist from the Mayo Clinic, and he was internationally famous. And I got to know him. And that was really great. I was 16, and he was at the end of his career, but he was a real interesting person. And getting to know him was really quite nice. And eventually I learned golf after 3 attempts. And that's been a great source of joy for me. But I tried in high school, failed, tried in college, failed. But technology arose, and I was eventually able to learn it. So that was next slide. Modern psychology. This is sort of a recent deal for me. It's like, as you may have surmised, I like to read. And I tend to read a lot. I always have. And I have really grown to appreciate modern psychology. And a little bit, it's like, where did it begin? And there's a book called Misbehaving, and it's sort of a history of modern psychology, which is called behavioral economics, or basically decision making. There is a book that I read 23 years ago called the Why Smart People Make Big Money Mistakes, and it was a primer on behavioral economics. And it was kind of a fascinating story because it begins with the work of Israeli army psychologists. And in reflecting on it, I was thinking that in Israel at the time was a small country surrounded by other countries. They had a couple million people against 200 million people, all of whom wanted them to die. And therefore, the ethos of Israel is you had to get it right, you had no choice. And these army psychologists, they did this elaborate testing on how to pick an officer, and they discovered it was wrong. Didn't work. Didn't do the job. Didn't pick. And out of that discovery, they went back and reworked it. And they were real interesting because the Israeli psychologists were Daniel Kahneman and Amos Tversky. And they were both lieutenants in the Israeli army. And what I subsequently learned from other books is that was a big deal. That was a really big deal. And in the Israel, there is no military academy. There's no West Point. There's no Annapolis. Everybody starts as a private, everybody. And so everybody has required service, and it's amazing. It's amazing how many people have. It includes women, and everybody owes them 3 years. And so in that, start as a private. And at the end of 3 years, you can work up to be a sergeant. And of the sergeants, they figure they pick the best, and they offer them the 4th year to be a lieutenant. At any rate, these guys came from very different backgrounds. Daniel Kahneman was a sort of a French Jew who lived during World War II, during the reign of terror in France. And Amos Tversky was a, what is it? Any rate, he was native to Israel, and they were very different. And basically, Tversky was unbelievably brave, and he won what was equivalent to almost the Medal of Honor for Israel, because a young soldier was doing a demonstration for a general public, and he was supposed to blow up something, and he fainted with a grenade in his hand. And he's the audience is looking on in horror. It's this young man is about ready to be killed, and Tversky was a lieutenant, leaped out and ran toward the young man, separated the grenade from him, and picked him up and ran and collapsed, and then took lots of shrapnel, and he saved the young man's life. He was slightly hurt, and he was awarded a major medal for bravery. And the description of it was Moshe Dayan, who's a famous Israeli general, pinned the medal on him and said, "Don't ever do that again." And it was really a very foolish thing, but they were real. They've been in the army, so they were real. They had stuff, but they came and they invented sort of empirical. They did studies. They did studies, and they measured, and they invented behavioral economics, for which Daniel Kahneman awarded the Nobel Prize in 1997, I believe. But he was not an economist. He was a psychologist. And in 2008, classical economics was proved to be wrong. This was close to 50 to 75 years of teaching, which is wrong. Man is not a rational creature, not at all. And so there's a series of books and things about all of these. And so behavioral economics is really solid about how people actually behave. So that really affected me a lot. And that's maybe the last 10 years. So next slide. I always wanted to be a doctor. I came from a doctoring family. Both my grandfathers were doctors. My father was a doctor. My uncle was a doctor. My other uncle was a doctor. And I liked them. And I liked their stories, and I liked them. And I always wanted to be a doctor. And I became a doctor, and I realized I hadn't a clue about what a doctor was, but it turned out okay. And next slide. And the key deal is that I had a role model in my father, and he worked at Scott and White, and he helped build Scott and White, and that was a great joy to him. And I really liked building stuff. And like my mother said, people grow up to do what they did in high school, and that's exactly what I did. Exactly. I organized things all over the place when I was in high school, and then that's what I've done the rest of my professional life. So I was fairly directed about what I wanted to do, and consequently, I went to Presbyterian in 1980, and I was the youngest medical director, youngest head of a department for years. I was 32, and I was the chief of emergency medicine, and that got me on the executive committee, and I got to do that for 25 years. And it was really marvelous, because I was lucky there. I was lucky because I had an administrator who kind of had a similar value system as I did. And he was my administrator for 37 years, Doug Hawthorne. But, that was luck. A nice thing is that I met my wife, Maureen Murray, in the emergency room at Parkland. I met her over a Russian with chest pain, and who spoke no English. So we were pantomiming various gestures, try to understand what was going through. At any rate, and I married Maureen Murray 2 years after meeting her, and we've been married ever since. And that was probably the biggest right move I ever made. We've had a marvelous marriage, and a little bit people talk about financial planning. Well, financial planning is not financial planning. It's marital planning. Because, you know, I married her when I should have. That is, I was not too young. I was experienced. She was not too young. She was experienced. And people, and you know, I have known hundreds of doctors, and I have been through divorces a lot. And I just, it is so sad. It drives me crazy. And watch two people just tear each other apart is just amazing. $1 million divorces. And so if you can avoid that.
Yeah. Hey, Compton, when Angela Gardner, who, for those who saw the talk last year, came on and spoke, Angela's past president of the American College of Emergency Physicians and one of our faculty, and a very wise lady. She was talking about financial advice, and she said, don't get married. But if you do, don't get divorced.
I asked one of the senior doctors who I really admired a lot. I said, did you learn anything from the divorce? And she said something which really affected me a lot. And that was, it said, I got married too early. And a little bit as all my friends were getting married and they were all doing that. And I never wanted to be alone. And so I clutched. I married too early. And I think that's a theme. And a homily I used to say is young men should never get married in medical school. And she said, well, I would amend that. And I would say, you should not get married in medical school. And, you know, that's a kind of heavy piece of advice. People with a relationship. However, I think that it's what's underneath that is like, why should you not get married in medical school? Well, that reason is the real reason why. And that is medical school is a very different experience, and one that you become immature. You actually devolve in order to become a doctor. And that immaturity changes. And so, and also one thing, it can be lonely, you know, and you're a 23-year-old young woman and you're lonely. And a big strapping guy comes along, is helpful, and, you know, etc. And you get married, and it's a mistake. And so, when there are two books that I recommend anybody getting married. Is one is the 5 Love Languages, and the other one is His Needs, Her Needs. His Needs, Her Needs turns out to be a really good book, and everybody who should read it. But at any rate, poor Angela had to go through the experience of getting divorced, and it hurt her. And so don't get divorced. Don't want to get divorced. At any rate, so I became, next slide. I became the chief of emergency medicine at Presbyterian, and thereafter I became active in the state. I'm currently I think the oldest alive Texas College of Emergency Medicine TCEP president. So, but I got to do that. I was very active in the TMA, and I did that. And in 1994, I was president of the medical staff for 4 years. And I was part of a group, and then the hospital wanted to merge with the hospital in Fort Worth. And my counterpart in Fort Worth said, well, if they're going to merge, let's merge. So we did. Next slide. In this time, 1998 was an active year. I had worked 4 years and got a master's of medical management at Tulane. And people ask me, why did I do that? Well, my answer then and now is I did it so I know what I did. I know how to do better what I was currently doing. I'm glad I did. And, in the current management, a concept is that if you want to be a medical manager, you generally have to have or will have to have a management degree of some sort. I think that there is a discipline of management. That there's an actual where there it's not BS. However, I think that if you're coming straight out and doing an MD, MBA straight, you are not doing yourself a service. You're not. So I don't like MD, MBAs brand new, especially on young people, because the operative degree is the medical degree, not the management degree. The management degree is not a professional that you have. It guarantees you nothing, but the knowledge base is fabulous. So I believe that the correct approach for somebody interested in management in medicine is to become a doctor. And I think a really good doctor. I think that I used to think, well, if you could be an okay doctor and really great manager. And over time, I have changed, and I think you have to be a really good doctor. And it's how people listen to you. Is that if you're a shitty doctor, you just can't be a good manager, no matter how good you are. You've got to be a good doctor. I mean, a really good doctor. So become a really good doctor first, and then get the management degree. That's how I did it, and that's what I recommend.
Compton, I think I think when you get a little age on you, one really finds out what a body of knowledge that you need to learn. And the term masters is to go become a master in something. There are things that I would love to go do now. I'd love to study a month of neurology, and God Almighty, study a month of just looking at CT scans of the abdomen, and so forth. But I think it's quite one thing to do a master's just because you're trying to fill out an application to med school, but it's quite another to get a master's because you really want to become an articulate thinker in a field.
Yeah, I believe that's true. And one thing about if you do the MD, MBA straight, you don't have enough experience. You don't have the questions crystallized in your brain, and basically, I think that you are impaired. And a little bit, this is another one of the things that we'll get into the books is that a question I've asked myself is, why do so many doctors who get their MBA not effective leaders? And I think that it's not their fault. And this is my analysis of it is that MBA schools teach commandership, not leadership. A commander is a major or a lieutenant colonel. And you could teach that because you don't have to be a content master. If you're a head of a lab, you need to know about laboratory medicine in order to have credibility with the management. In medicine, if you're a surgeon, you have to be a good surgeon. So the leadership part you learn as a doctor. And, like an emergency doctor at minimum is like a fire team leader. You're leading 4 people or 5 or 6, or you're a captain of a football team. 11. You're a captain of a basketball team, 5. Your leadership is small units. And there's a book on that, which I'll get to later. But one of the things was nice in my career is I got to be the interim medical director of Parkland's ED for 6 months. And that was my administrator at Presbyterian. There was some problems in the leadership, namely the leader at Parkland was sick, and there was a vacuum. And so I came in and sort of did the little Dutch boy thing, and was a medical director. And ultimately, Paul Pepe came and really put emergency medicine on the map. I became the chief operating officer of Emergency Medicine Consultants, which was the big Harris and Presbyterian. And that was the start of what would eventually become a 300 doctor, 100 PA, NP group. And it was very satisfying in that I was became a president of the leadership council at the time, which is sort of like a giant medical board for all of THR, which is Presbyterian and Harris. Next slide. I also became a board member, and being a board member made me see sort of like what do board members do, what do senior executives do, and it's sort of like the emperor's clothes. They're people too. They have the same things as when I was an orderly. Then I became a board member of Texas Medical Liability Trust, which is the largest malpractice insurance company in Texas.
So, Compton, let's take that point for a moment. I didn't mean to interrupt you in mid-sentence, but I do want to talk about that part just for a moment. Finish your remark, but let's talk about what you learned from being on the board of the Texas state. Texas, that's a huge state, medical malpractice company. What did that teach you?
Well, it was kind of interesting because first off, we have pre and post, because I was on the clinical risk committee for a long time, longer than that. So at a time once, Texas was a horrible state to practice medicine in. Everybody got sued a lot. And in the early aughts, there was a giant battle between the plaintiff's lawyers and medicine. And this was at the beginning of the Rick Perry era. And it was a giant because we were literally, there was one insurance company in Texas and they were leaving, and we were going to have no insurance. And it was around the early aughts. And I tell people my story is that we had maybe 150 doctors who were looking at being uninsured. So, I think that a little bit practicing without malpractice insurance is just insane. And literally that's 6 hours. So the senior partner in our group went to Austin and to talk to the head of Texas Medical Liability Trust. It was the only insurance vehicle at the time that was viable. Everybody else had left the state. Everybody else had abandoned Texas doctors. And we had 17 doctors that they were thinking about not insuring, 17 out of 100 or so. And he went down and basically told them the story. And that one man decided to insure all of us. And we became a member of the Texas Medical Liability Trust. And also I tell the story about the value of political advocacy. And I say to every young doctor is you get paid $36,000 a year, every year, courtesy of our tort reform.
Explain what tort reform means.
Tort reform is that tort reform is we have in Texas us in California have, and it's related to one thing. We have caps on non-economic damages. Non-economic damages. It a little bit. It's economic damages are a. It's an open-ended deal. In other words, you can't insure it. If a human life is worth infinity, and a common deal was this guy experienced X amount of anguish, and you do it by second. How much is a second worth? $50, $100? Well, that's $20 million or 30 or 40. And so there was an unbelievable war between the plaintiffs' lawyers and the doctors, and we won.
And Compton, if I may comment, tort is a kind of law for the students, and a tort is a personal injury. And so when a patient sues a physician for malpractice, they are suing as they were personally injured by the physician, and that's called a tort. And so what was happening, as Compton was saying, as Georgia was when I left Georgia 20 years ago, that just a lot of lawsuits going on. Texas says we are going to reform tort law, personal injury law. And Compton, you want to pick it up from there?
Well, a little bit to me is because, like, like for example, if you look at the advertisement for Jim Adler in Texas, well, that guy makes a fortune. Or Henry, I mean, he's driving a Rolls Royce, has a plane. Well, those guys can pay for that because they get paid a fortune. And like a portion, they don't really talk about how much do they pay. Well, we got millions of dollars for my client. Well, also they got millions of dollars for themselves. So, I mean, I basically don't like plaintiffs' lawyers. However, it's a giant, and this deal, it's you have action economic loss, you get that, but the non-economic having a cap on that makes the entire enterprise of insurance possible. You can, like insurance. Little bit is when you buy insurance, you're buying to cut your risk, and generally it's you pay me money now, and I try to not pay you money later on. But it's a big deal so the tort battle resulted in a reduction in malpractice costs of about $36,000 a year per doctor per year in emergency medicine. So it's, and people, a little bit is the people don't remember that. And they need to remember that when people say, well, like this guy was really hurt, and he was. But they're disingenuous about telling the true story. So also we're in different states, and like Florida is going to go out of business. They're going to sue their doctors into oblivion, and that's hyperbolic. However, it's not when you know a little bit about insurance. Is that the end result is when the reinsurers no longer write, therefore you're not insured. And like a bad story would be like in New York one time, I read that a person paid $200,000 a year for a $50,000 policy. Well, I mean, at some point, that comes from somewhere, and it comes in a tremendous cost. So I have my time on the the trust board is over now. Well, we will be over at the end of this month, but it was during the time of tort reform, and tort reform was really great. So we really did pretty well. In 3 years ago, our group of about 300 doctors became part of Team Health, and people comment there is that it's part of medicine. And I think that there are bad things about it. However, there are 4 insurance companies that cover 90% of population in the United States. That's 4. And basically, it believes in power. And so, if you're a large group, you have some power. If you have a small group, you don't have power, and that allows you to get paid. And it's all power politics. And also, as medicine has gotten bigger and more successful, it's more of a team game. And for the just private practice, go out and hang out your shingle and make a living is becoming less and less. So medicine is becoming more and more corporate. Any rate, I won a nice award from ASAP in 2018, and then right now I'm mostly retired.
Well, don't blow past that award. The American College of Emergency Physicians that Compton and I both saw at the very beginning is a huge national organization of board certified, now residency trained emergency docs from all over the United States, over 30,000 members strong. And a mere 3 years ago, they recognized this man, your speaker tonight, as the outstanding servant to the field for that year. So Compton and all of us who know you know how well deserved that award is. So congratulations to you, Compton, for that. And then in 2021, you did what?
Well, I'm mostly retired. Like I'm still active with my former group, but mostly that's just listening and asking questions. And in my career, I have learned a couple of things, and one of those things is the question is your friend. You can ask questions, and questioning is almost never perceived as bad. And also a second thing, which I learned from a former Parkland resident, is the value of curiosity, being curious. And so maintaining when you're in conflict with somebody, really trying to understand, being curious about how they came about that. And the third thing is I really like a question that begins with how. And I really don't like a question that begins with why. So over time, I become more, don't ask somebody why they did somebody, ask them, how did they come to that decision? And I think that the how question is much easier. The why question is generally why in the hell. So like it has a negative connotation, and it creates. But if you ask how they came to that decision, it generates a better conversation. Next slide.
So Compton, we now have a bunch of questions that have been posed to us in chat, and Taylor is going to take it away.
Okay.
Yeah, we have some pretty good questions so far. One of the questions that we got was, what kinds of issues do you think that the next generation of doctors will have to solve?
Okay. Well, the organization of medicine, I think that okay, solving the future is not generally possible. However, you can look at the forces, and I think the medicine is now 51% women, and I think that portends a really different future, and I think a good future. and this is going to be somewhat politically incorrect, but I think women are better thinkers. They're more measured. Studies about women investors, they do better. They're, like another concept is and I quote this person as sort of a joke, but it's kind of not, is testosterone is a neurotoxin. You have pride and that sort of stuff. And so I think whereas a women is a big deal. I think I would say the medicine is becoming more corporate. It is becoming more organized, and that's good. And that's also bad because doctors are not inherently brave. Most humans are not inherently brave. And, when you're told to do something that's bad, what do you do? And I would say this maybe in history, Nazi doctors, German doctors are part of the Western tradition of medicine. The four ethical deals: non-malfeasance, beneficence, autonomy, and social justice. And those tenets of ethics, which dominate Western medicine, the Nazi doctors didn't do. And I think that's a something that is potentially a problem, because I have seen it just a little bit, not much, where I asked one administrator, if you had a chance, if you had to comply with a rule or do what's best for the patient, what should you do? Well, his answer was comply with a rule. And so it's very, very important to be involved. And like primacy of patients and the four tenets of ethical care are very important. So I think that so far, I would say that has not happened. However, it could. And we're seeing a little bit of that is where, and so I think I think we're in a little bit of a, I think Texas is kind of is testing testing it a lot. I think that abortion is a very hot topic. However, I don't feel that I'm a pro-choice guy. And it's telling women what to do, limiting their because I think that at some point in time they say, well, life is sacred. Well, okay, when does it not become sacred? Having a child is a big deal, and it's at least a several $100,000 endeavor. And I think medieval thinking is dominating right now. But I think that I'm seeing it with doctors, and there's some things in the law which are bad. And I think that now the counter to that is that, like, I think there are people of conscience who are really, but I ask, well, like, who's going to pay for this child? When does a person's life become not sacred? Like we were talking prior to the deal about some heroin shooter. Well, he's somebody's little boy, the alcoholic who's drinking himself. When he's somebody's little boy, baby, when do they not become sacred? And so I think that the risk for medicine and being a product of a success, which is major organization, is that major organizations have gone awry a lot, namely, in using the most common lesson is Nazi Germany. or so that's going to be a pressure that you will hope your leaders keep you out of. I think that vigilance and fighting are something we cannot take that for granted. We must not take that for granted. That's my big worry.
Well, thanks for sharing that. Moving on to another question. So what three qualities would you say are the most important for any good physician to have?
One is really, it's very easy to say and it's very hard to do. And that's to listen. And listening is really hard. And the older I am, the more hard it is, because you want to listen to what they say and what they don't say. And you have to know a lot about humans to listen about what they're not saying. Because in the emergency room, all patients in the emergency room are afraid. Everyone is afraid. And Ray is experienced with that, where somebody comes in with, they think it's indigestion, and shit, it's not. It's not. And so listening and interpreting and listening it's probably the one is listening. I think another one is I think that I read a book about persistence and grit. I think having grit helps you. I think that probably a third thing is having this is going to be sort of trivial, but I think that a sense of humor, because you're constantly being bombarded with the whimsies of life. And having a sense of humor helps you get through it. And over time, people with senses of humor do better, because people who feel everything and get mad at everything burn out. So maybe that's, amongst the many traits, but those are three that I would put at the top.
Compton, many years ago, you defined burnout for me. Could you share that again?
Well, I like the definition of burnout I like the most is from Brian Williams, who is an ex-trauma surgeon. And his definition of burnout is the response of a normal person to a toxic environment. And I think that right now there is a lot of, there is stuff about resilience. Well, that's in some ways wrong, because that is assumed that you don't have enough resilience. Well, I think that right now, the problem with medicine is fixing the system. I like the concept of human engineering, and the human engineering interface is imperfect, namely electronic record. A lot of the system takes the joy out of medicine. Now, there is a lot to joy to be had. There's a lot of things you can do. However, I think that working on the system, that system tends to, not be the focus. And I think it should be. And I think it will be. Because like right now, the great resignation, because people are, and you have the medicine is a female workforce. So it needs to be more family oriented. You need to have childcare. Need to have, be able to work, 5 hours at a chunk, not 8 or 12. So working out that, I think that's another challenge, and that's doable. That's really doable. I really like the concept of, in emergency medicine, I like the concept of results only work environment. There are 168 hours in a week. You work 40 of them. That leaves 128. 56 of them are sleep. So that leaves 40 and 56. That's 96. So that leaves you 72 hours of other time. and how you take care of that. And like the work family dynamic is that medicine has got to realize that. And the thing is, it'll become better because of it. Anyway, that's a long answer.
Yeah, that's great. Taylor, one more, and then we'll go to the next half.
Okay, so Dr. Brothers, how are you feeling about retirement? Do you think that you'll miss medicine given that it's been a lifelong career for you?
Well, I'm kind of not really retired. I have projects that I care about and I'm working on, before I have my golf tournament, and that's to benefit Parkland. I'm very interested in wellness and in that aspect. I'm interested in my group, so I'm part of that, and I'm interested in Parkland. I'm part of that. So I have projects now that what it allows. I'm not taking care of individual patients, and not by not doing that, I can focus on this other stuff. So I'm kind of not really retired, but I'm working on the stuff that I like. And so I'm not gone to play golf every day. That drives me crazy. So I'm having that.
Well, that seems like a good outlook. Kind of lets you balance what you like to do and what you used to do, and just kind of to continue doing it.
Yeah, well, I can pick and choose, and I can in the things you're doing, I'm blessed in that I can participate in that in a financial way. And I know hundreds of doctors who are still in practice, and it's really supporting them is kind of a joy, actually.
Well, we're appreciative.
All right, Compton, let's talk about some of your reading material.
Okay, well, I like to read. Next slide. Books that I have read that continually come back to me, and that is The 7 Habits of Highly Effective People. It was written a long time ago, and I try to remember the 7 things. But the most important thing is to seek to understand before being understood, and that refers to the listening aspect. That is really very, very hard. And in this era where there's a lot of noise, you've got to learn to listen, and so it takes skill to do that. So that's be proactive, begin with the end in mind. First things first. Think win-win, synergize, and sharpen the saw. Sharpen the saw means that refers to meditation, exercise, other projects, developing yourself. And I think that those 7 tenets are still very, very good. Begin with the end in mind. Like this project of shadowing, the end in mind is being medical school. So think about that. And also, I really like How to Win Friends and Influence People. It was written in the 20s. And it's still a little antiquated, but it's really true. And the fundamental tenet of it is to generally be interested in other people, be genuinely interested in other people. And one of the things I learn about that one right there is learn their names. Learn their names. At the beginning of my career, there was a belly pain in room 2. There was a headache in room 3. There was a laceration in room 7. And that is not good. Learning there's Mr. Jones in room 2 with abdominal pain. There's Mrs. Smith in room 3 with chest pain. So having that as a general thing it's very important. And like in emergency medicine, you work with strangers all day long, and they have to trust you. And learning their name, and a little bit it is that I am, and challenges for you all is to learn the not traditional names. the Thai names, the Hindu names, the Indian names, and learn. And because like when you learn them and you say them and you say them right, you get lots of cred. So that's a challenge that I didn't have to face, but you will. And so learning people's names is real important. So every patient is a person, not just a condition. Next slide. One of the things that are interesting is I'm a Bruce Clark fan, and most of you have not heard of Bruce Clark. And Bruce Clark is a magnificent writer you've never heard of. He was a general in the Battle of the Bulge. You never heard of him, but he was a very quiet man, and but he was really a profound thinker. And a book was written about him as Bruce Clark, the Sergeants Generals, and he really believed in the middle management and educating them. And he wrote, his principles were in the middle 40s, and it predated all the fancy literature in the 80s and 90s and aughts. He's way ahead of his time. If you want, I send you I sent it to Taylor, a general principles from General Clark. But his story is just magnificent. And so it led me to a reading about lesser known people in history. And there's a lot of lessons to be learned from the quiet people. And everybody knows about Patton and MacArthur and all that stuff. But the quiet people really have a lot to teach, and he has a lot to teach. So I like those. The small unit leadership is written after Vietnam. And it is really, I give it to facility medical directors, because it's how to lead a small unit, a squad or a platoon. And it's really, really quite useful. And the coaching as leadership is where I got the how question. It's really marvelous. Psychology of Military Incompetence is it's an ancient book, but it was kind of interesting because in the military, at least the old military, your physical courage was what got you promoted, but it was your moral courage which allowed you to do the job. And it's sort of an old book about that, and it really began to crystallize in my mind the importance of moral courage. And that is something that's not taught in medical school. It's not taught in any school. So I think courage is something that is something to, and also I've wondered, can you learn courage? I think you can, but it requires thought and introspection and knowledge of yourself. For example, I'm not a courageous person. I'm not. And I have done cowardly things in the past. And I've done some not so cowardly things because I had learned. So the Southwest Way is about Southwest Airlines. It was written maybe 15 years ago, and it's about what Southwest Airlines did right. And they've gotten so big that I wonder, however, there's a lot to learn from healthcare, because it talks about relational coordination and, pilots, baggage handlers, flight attendants, front desk, how they work together. And it's really a fun read. And You're Not So Smart is really a journalist's approach to modern psychology. It's 46 chapters, and it's all the ways we think badly. It's an easy read, and I say people, you can read it in total. Maybe takes 10 hours. You can read just the it take you for about an hour to read the first half a page of every chapter. So you can get a gist of it pretty fast. But a mainstay is that humans, a fundamental aspect of humans is that we all live in our own reality. And we tell a story about ourselves every moment of every day that makes us look good. And that drives a lot of behavior, almost all of it. And Managing the Unexpected is a book I've given maybe 40 copies of it because it talks about the reliable organization, and it's a study of aircraft carriers. And the preface of the book, it says, what is an aircraft carrier? Well, it's a nuclear reactor floating in the sea, covered with bombs, overwhelmed with jet fuel, run by 20-year-olds. And it has, and it has a 70-year history of no accidents, and how do they get that way? And they have 5 things they do well. And the first thing is that they become obsessed with failure. You have a failure, you study the hell out of it. You find out all the things that do. And that's a real lesson for medicine. We have mistakes that occur in medicine, and we tend to either blame the doctor or blame the nurse and go forward. And we don't look at it, the details. The second one of the things to recommend is don't oversimplify things. We do it in medicine all the time. We blame the nurse, we blame the doctor. We don't look at it, we don't break it down, and they avoid simplification. Do not do that with a problem. And they look at bad events, and generally there's five to six times when it could have been reversed. So in the Swiss cheese model, and the third thing they say in Managing the Unexpected is have a reverence for operations. Get in the weeds. The fourth thing is be resilient. Redundancy. Have systems after systems that prevent things. And the last one is have an absolute dedication to the front line. In the front line, that's where a lot of hospitals don't get it. And that is where you're liable to do that. And the front line is for example, it's the sonotech. The radiologist said something, but the sonotech really saw it. So getting down to the nurse and the technician, getting down to the sailor who made the mistake. I learned from the Ebola event in 2014 is that they didn't really get any good advice from the CDC until they talked to the nurses who have actually taken care of the patient. Those were the real experts, not some PhD or MD guy. It was the guys who really actually did it. And so from that, I said, if somebody says they're an expert, you ask, well, how many of these have you taken care of? And if they haven't, they're not an expert. They're just not an expert. Next slide. Freakonomics. I love Freakonomics. I absolutely love it. Its first tenet is that you follow the money, always follow the money. And how that relates to medicine, relates to reading, is it really helps to know the bias of the study. And the bias is driven by who paid for it. If a drug company paid for it, it's biased to show the drug worked. If it's a government who paid for it, the bias is show it didn't work. So knowing the bias really helps. So, and looking how a lot of people is, you always, follow the money. It's like, was it Sutton? Always go where the money is. It allows you to understand a lot. The second one is don't trust experts. And the third one is conventional wisdom is almost not always wrong. And that is like a doctor is an expert, but you have to say, when you really reflect on it, where'd you learn that? Again, reflection and skepticism is very useful. The fifth one of the Freakonomics things is really cool. It's like, if you can figure out the what to measure, you can really, it drives the organization. And I like to use an example of that is like, what is the entire US government dependent upon? Payroll deduction. Payroll deduction is powerful. If you're a $85,000 a year plumber, and every April you have to pay $15,000, you have to write a check. Imagine what the government would be like. But if you don't ever have to write that, it's you never see the money. You get paid $60,000, and otherwise it becomes a refund. It's payroll deduction. So finding out what the major how to measure the systems, and sometimes small things have big consequences. And and with reference to that, I'm thinking about the Battle of Trafalgar. I'm sort of a weird thinker. The British could fire 3 times as fast as the French and just beat the crap out of them. And it was because of the flintlock that fired their cannons. So small things can have big consequences. In the other book, How Full Is Your Bucket is, I've probably bought maybe over 100 books of that. It is
Oh, well, Compton, let me comment that the reason you buy so many is that you give them away.
Oh yeah, no, I give them away. And I really like this book because it takes 2 hours to read, and it'll change your life. And it starts really well because it starts at the baseline. How to be unhappy. Not how to be happy, but what does it take to be unhappy? And it's a study of prisoners of war in North Korea in the Korean War. It absolutely did a fabulous job of making them miserable. But it's a really good book, and it'll change your life. The next book, On Combat, the Physiology and Psychology of Deadly Conflict, is really interesting. It's really interesting. It's where I got the concept of your physical health helps your mental health a lot. And it goes into, like, for example, you get shot, you almost never die. You almost never die. And it told a story about a young woman who was shot in the heart. And she had a couple seconds, and she killed the guy who shot her. But she had seconds to live, and she used them. But it's and it's also about, like, when you get a heart rate above 140, you're crazy. You're just, like, and it's a reason that they tend not to recommend high-speed chases. The Rodney King affair, those guys were they were crazy. You become psychotic, and they did heart rates and high-speed chases, and they're up to 200, 180, 200. You're so jacked up that you just don't think. You commit stuff and you don't even know it. So it's a thoughtful book, and really it's kind of a scientific book. It's pretty good. And also, one thing in there is that they looked at PTSD. And one of the things was the critical incident debrief. And what I got out of that is not a psychological affair. said the best things is where you have it, you have everybody gets together and they tell their story, because it's the reality is all distorted. It's all distorted. Everybody sees reality differently. And you just go through the facts. You go through the facts, and and this is run by a senior police officer. It's not run by a psychiatrist. It's not run by a psychologist. It's run by a person who's actually been in those situations. And I like that. And like in the emergency room, it's like you have a death of a child. You have the team gets together and dissects. What did we learn? What did you do? What did you do? You know, what do you think? And you sort of lay it all out, and then you deal with the psychological aspects later. And it was quite nice. And also it said something which I really loved, is that like the autonomic nervous system is uncontrolled by the brain, except with one thing: breathing. So they had the concept of combat Lamaze, like, you know, deep breathing. And breathing is a way that you can lower your heart rate and get control. And I never had that idea of like the autonomic nervous system is running on its own, but you can control it with breathing. So what it sort of took I'd previously thought it was sort of magical, you know, breathing is sort of like, but it sort of put it in physiologic terms. And I kind of really liked that. So I like the concept of combat Lamaze in the emergency room. Like there are circumstances in which you're just scared to death. And in my own career, it's like a dying child. And, you know, there's an absolute need for an IV. And, you know, this is before we had interosseous.
Yeah.
Interosseous. You know, I remember doing cut downs on little tiny ankles and trying to thread a catheter, you know, the size of a hair. And, you know, you've got, you know, you're shaking and, you know, having to control that and doing it. And that's, and it really spoke to me. It's a very, very good book. And Core Business is about the Marine Corps. And it's also a very fascinating book, because the Marine Corps had the 70% rule. And the 70% rule, when you're sure 70%, do it. And so it talked about how when you're never sure. And the 70% rule really allows them. And so it was really quite useful. Great Leadership is a very dull book, but it really relates. It's a good book for how to be a manager, because it really emphasizes the importance of courage, and courage and humor. And having the ability to talk with humor is a great way to have, when you have tight events, when everybody's really jacked up. But it's kind of dry, but it's a good one to go through. In Drive, really, I like the book because it talks about the three things that really drive people, and it really speaks to doctors and to mid-levels. It's like autonomy, mastery, and purpose. And what do we want? And it talks about how generally highly motivated people want autonomy, mastery, and purpose. And they're not driven by finances. Like, you know, good doctors are not driven by finances. They're not. Good PAs and good nurses are not driven by finances. But a little bit is create a work environment where you have autonomy, mastery. You help them become really skilled at their job, and purpose. And fortunately, in medicine, we really have a great purpose, a fabulous purpose, and that is something we always need to remember. It's we do really we have great jobs. We do great work. Next slide. And this is, some thoughts. Humans live in their own reality, which looking good is paramount. That drives almost all behavior. Another thing I've learned, kind of courtesy of my brother, and that a main principle of a large organization is to keep your job. And in order to do that, you have to keep your boss happy. And if you have a $350,000 a year job, which you can lose overnight, you pay real close attention to that. And again, and one of my worries is a chief medical officer will, in a large organization, he's told by his boss, well, we're losing money, so therefore we must not do this. He's given some sort of ethical problem, and he goes along with it. And he says, and that's bad. But like I've never met a COO of hospital say, I'm going to do everything I can to get fired. Doesn't happen. It never happens. And that's so those are the two things that are, I think there's another slide.
That's fine. Yep.
One more.
Yep.
Okay. This is a comment. You become what the rules make you. If you are a doctor and you are in administration, if you don't practice, sooner or later you become an administrator. You're not a doctor. And I believe that doctor leaders should be doctors. They should always be doctors. And so practicing like Ray practices, Brandon practices, Gil practices. And so that is the secret to staying connected with what drives you. I think that it is probably, and this is going to make somebody mad, is that it's probably one of the major problems with nursing, because their leaders don't work. They don't nurse. And nursing is really very complicated, and their leaders don't. And I'm worried about doctor leaders who are not doctors, because they become disconnected. And a last one is that, I read this and it really resonates with me. And a common sense and a sense of humor are the same thing at different speeds. And in observing hundreds of doctors, that's pretty good. That's pretty good. Going back to courage is it like, I wish that we had a class on that, or classes, because I think you can learn to be courageous. And I think it comes up when it comes to bullying. Bullying is very ubiquitous in medicine. And I think it's it is allowed. And an example is like a nurses are really good putting in IVs. They become a charge nurse, and therefore they beat the hell out of everybody else who's not as good as an IV placer, and they're not taught. So teaching courage about how to advocate. And that's when a couple of years ago, there was a nurse who stood up against a sheriff, and he arrested her, and it was in Utah. And it really struck me is that where were the doctors? where were the doctors? And I was thinking they weren't there. This nurse was sticking up for this patient, was doing the right thing, and the doctors weren't. And like another example of like a doctor who I was extremely proud of, one of the hospitals I was associated with, this doctor stood up against a sheriff in reference to a patient. And the sheriff was really kind of an asshole. The doctor stood his ground, and he defended the patient, and it was good. It was like really good. But I think that simulating those situations can allow you to pre-think, because when you have the situation where you're required to be brave, you don't know what to do. And I think that is, and you're frozen, and like you're maybe brave, and maybe these are seconds. These are seconds, and you've got to be trained. And so that's just a thought.
You've got one more, Compton. Let's do that last slide that we had a little joint thinking on.
Well, these are ruminations, and this is where Ray and I this is what the joy, and it is, medicine is a great adventure. One of the things it's kind of continually amazing me is like, there is every shift you have a challenge. Human beings are really unbelievably varied, and so it's a fabulous profession. The patient, I've been lucky in some ways that I've been a patient for the last couple of years, and I see the value of the kindness, an extra bit of water, some help. And like, patients are really, it's no fun being a patient, and it's embarrassing. And a provider who can take care of them with respect is really, it's a joy to see. I mean, I remember watching a technician help a little old lady to the bathroom, and it was an art form. I mean, he was balanced, treated with respect. He's picking her up off the commode. He's helping her. I mean, it was just magical what he was doing. It really affected me. And like, you can learn, you can, as an individual, learn, and patients teach you. The clinical experiences teach you. All the guys there. I know Ray, and I know Gil, and I know Brandon, and they're all fabulous, and they're marvelous people, and it's a great job. It's a great job.
And Compton, don't you believe that it's really a partnership between the patient and the provider, and it's almost an oath that we swear? Do you believe that?
Yes, I think right now is like, I think that partnership is in the patients want a partnership is like this. And like in the old days, it was all this way, the doctor and the patient. And I think in the new era, it's more this way. Autonomy is one of the ethical premises of medicine, and like engaging them, and like frequently about being skeptical, having discussion about treatment plans, and being open to, because I've been in a situation where like, I think I know what you need, and and you're full of it, and I was wrong. You can have a dynamic. And I mean, I remember one of the things I'll never forget as an intern, there was a renal failure patient came in, and his wife was absolutely fabulous. And I was smart enough to realize that I just needed to I needed to write down what she wrote. I wrote the orders, and she wrote them out. I mean, literally, she knew. I mean, it was what diet, what was, all these things, and she knew it. And it was the dynamic was the patient really knew more. The patient's wife knew more, and I was smart enough to realize that. So it's and when you become a patient, you realize that because you are real sensitive to, because he's gonna look down on me. He's gonna be, and when you don't do that, that's when you've really done well.
In that partnership, I think, Compton, we are obliged to listen, to think, ruminate. The difference between a specialist in a field and a generalist, an average clinician, is in the rigor of the application of a differential diagnosis, that you really know what you're doing. And that's the challenge that we're presenting, I think, this evening to the over 160 that are still online with us, is that you've got to get good at what you're doing. A frustrating part, and I think this is something, Compton, that contributes to burnout, has to do when we don't feel like the partnership is being held up on the other end. The drinker who won't stop drinking, the person who's shooting IV heroin, or things less dramatic than that. Someone who won't take their hypertensive medicine, but I think the critical thing is that it's a sacred oath, and we have to reestablish that partnership from time to time. I think we do.
Well, I think one of the things is that we right now, a common term is social determinants of health. And a little bit is people who the drinker who won't quit drinking. Well, maybe there's a reason he's got diabetes and his foot's lousy and he's homeless and doesn't have a house and his family doesn't talk to him. Like, shit, I drink a lot. And so I think that realizing that and realizing conditions and realizing what you can do and not do, and a little bit to me, it's a challenge of professionalism, because there are some people that you take care of, you just don't like. You just don't like them, but you've got to take care of them anyway. And that's true in emergency medicine. And like, if you can do that, and that allows you to do a good job all the time. And professionalism means that you do the best you can and you don't become a judge. You're not in the judging deal. You take care of them as they are. And I think but that requires work. That requires work. And that's a big burden. And I think a beginning answer to that relates to your own health. And like, I remember when I was a resident, I was tired. I was at the end of my 24-hour shift, and there was a patient I was admitting, and he was drunk, and I was thinking, I take care of, I'm caring for you more than you care for yourself.
That's right.
And I was thinking, a scary thought I was thinking, like, if it weren't for social rules, I could kill you right now and go to sleep. And I'd wake up in the morning, feel fine. And that scared me. That really scared the hell out of me, because that's a shitty thought for a doctor to sort of come to that conclusion. But I was tired. And so and again, looking at the system deal, the system promoted that. I was incapable of coping well with him. And so that fortunately, the system of education right now is better. that we don't, terrorize people with 36 on, 12 off, 36 on, 12 off, because that you learn a lot of medicine, but you lose a lot of medicine.
No question. I had a patient not too long ago who came in with a swollen abdomen and petechiae eye, little red spots all over. And I got the liver enzymes back, and it was really concerning that this was a middle-aged person with alcoholic liver disease. And I sat down to have a talk with the person whose spouse was there in the room also, and quite supportive. And I said, I think that this is alcohol liver disease, and I need to talk to you because you're pretty advanced in the disease, and this is the first time you've sought help for this. And I need to talk to you because there are folks who simply cannot take a drink at all, because if they do, they will drink an enormous amount and it will destroy their liver. And the patient was a very nice person and said, gosh, giving it up. And then the patient said, can I still drink the communion wine? and I checked on the patient later. I read the admitting doctor's note a little bit later when the patient was up on the floor, and the admitting doctor, who'd had a long conversation with this patient, said, I am deeply concerned with the recidivistic nature of this patient's drinking, meaning that the patient is just not going to be willing to stop, even though fully confronted with the fact that this was destroying this person's health and was going to surely die. It's very interesting watching patients face their own demise, whether caused by themselves or not.
I would say that right now, I'm rested. I'm rested and I can cope. And like the condition of that person's life, that they're committing slow suicide. And so like, why would they do that? And so I think that you have to go to the reason why. And like, and I think that this person doesn't want to, take a 357 and blow their brains out, but they rather drink their way. And so that they really don't care. However, if you look at their life circumstances, they're many times it's like there are no other options. There are no other options. And I think that like, I think that you have a quote moral responsibility to say that. However, I think you have to let it go because they don't want to, and you treat them well as you can this time, and you tell them, it's like people, it goes back to people have a story about, and they make themselves look good. And like, here's a guy who likes a drink, and it's his only control is he drinks when everybody else tells him not to. And the logic is completely against him, but it doesn't matter. And you don't change those people's mind. You don't. You got to figure out a way to love them despite it. And that takes work. That takes work, a lot of work. And in order to do that work, you have to take care of yourself. You have to take care of yourself. And like, right. And if you're, and one thing that I was at Parkland part-time most of my career. And the reason is because I couldn't take it full-time. Because like you're awash in that all the time. And it takes real work to care for people who don't want to care for themselves. But you have to. And and so I could be at Presbyterian, take care of that kind of patient. And then I could, 3 or 4 times a month, I could come to Parkland. And I had a great career at Parkland part-time, but you're being at Parkland all the time. It's like you're in a sea of that. and it's unbelievably exhausting to cope with it. And also I think that there are some people who are really good at it. And like my reflection on that was Doris Nelson. You never knew Doris Nelson, but Doris Nelson was an absolute giant. And she was the battle axe who wouldn't let Jacqueline Kennedy back to see her brain destroyed husband. But she had a heart of gold, and she could take care of a 14, 5-time multipler with grace and calm and not get mad. And just, it was just fabulous because she was a paradox. She probably was one of the ugliest looking people I've ever met. Weighed about 300 pounds, had a giant mole right here with hair sprouting out of it, an absolute angel, and just a great nurse, one of the greatest nurses I've ever met, and a real role model for interns like me. But she could do that, and it was a marvelous thing to see.
So Compton, with the last line, perhaps it is in these relationships that we and our patients both grow. We grow in health and wisdom with the passing years. Could you make a concluding thought about that?
Well, the nice thing I can say is being alive is really adventure. And I've learned a lot about myself, maybe the last 5 years. And so it's kind of amazing about like how you're 70 years old and you're still learning about yourself. That's kind of cool. I think that being a doctor, being a frontline doctor, it gives you some understanding, about life. I think that it's in emergency medicine, every at the end of every shift, there's euphoria. And I was amazed that lasted for 40 years. Leaving in the afternoon or leaving at, 12 o'clock at night, you walk out, you say, man, that was fun. And almost invariably it was. And so it's a good career. It's really worth your time. But there are other things. There are other things, and there are ways to serve. And I think that serving is a little bit, the admonition is better to give than receive is really, really true. And looking for ways to do that is kind of fun, actually. So,
Compton, I sitting in the faculty club, I've gotten to know quite a number of people there, and I got to know Mike Brown, who's one of our Nobel laureates, and a very nice man. He's pushing 80 now. He may be 80 now. And we were sitting there one day, and I said, Mike, we got to know each other. I said, are you ever going to retire, or are you just going to be found stiff and cold in your office one day? And we both laughed about that. And then he turned around and he said, Ray, let me tell you something. Never retire unless you have a compelling interest at home.
oh
And I
yeah,
got to thinking about that. And Compton, I don't. I used to play the piano a lot. I read a lot of books, but I don't have a compelling interest at home. So I keep working. Do you have a compelling interest at home?
Not any single one. I think I like, people ask me, what do I do? I have a list of 20 projects on my phone, and I'm a project guy, and I like that. And I still, because of the foundations and the financially, I'm okay. So that allows me to help you and continue, and that's a joy. And that allows me other things to continue. And I'm not like dead. I don't play golf all the time. but I'm continuing uh, the ministry, so to speak, because I have various, like I have the golf ministry, the knife ministry, the flashlight industry. These are all, people who need flashlights or knives, I'm your man. People want to play golf, you know.
You gave me one of these. I got it right here.
you know, the
and notebooks. You gave me the notebook.
Oh yeah, well, listen, yeah, here we are. So there are all these things, and I look for targets of opportunity. So I'm very engaged. But but I like this right here. Your virtual shadowing is your job for the rest of your life. You're going to be able to do this and connect and help answer questions and learn because like you've that's my perception. You have invented your next career, and that the virtual shadowing will be. And you also, like, one of the great joys of academia is being involved with people like Taylor and Aditya, young people, and they keep you young, and it's great. And so your career is kind of fixed for the next 5 years.
Well, I hope so. Well, Compton, and we, for the virtual shadowing team and all of these wonderful kids that are online, as they know, kid is a compliment. We're just deeply grateful for your support, the financial support, that because there actually are real costs to running this operation, the mailer thing and the Zoom account and so forth. And so we just, on behalf of the whole working group, as well as all the folks online, we are deeply grateful for your support. And Compton, as you know, you and I have traded books back and forth, and I bought this for you. And let's see. It is the authority.
Stephen Breyer. Oh, wow.
Yeah, it's the authority of the court. I'm sorry, it's not focusing very well. The Authority of the Court and the Perils of Politics by Stephen Breyer. I have your copy. I have mine too. Whenever I buy one, I buy two. And so when we have dinner next, this will be my gift to you. So Taylor, let's move to a couple of last questions. And we are going to let Dr. Broders retire into his evening.
Okay. In terms of medical education, what are some structural and institutional changes that you think are needed today?
Well, one thing is, I think that looking at the admission process, the admission process it's extremely hard. It's extremely hard. But I have two examples of where the admissions almost got it wrong. And one of them was related to a resident who I did not know, but I know of. And he went to after several tries, he went to a Caribbean medical school. And then he transferred to a sort of lower tier, American medical school, graduated. And he was the number one guy in his number one on his in service 3 years in a row in the whole country. And he was clearly he's a brilliant doctor, and he's a nice guy. Like, why did all those American medical schools pass it up on him? Why? And the another one was a nurse who's the head of the group I was formerly with, and he was admitted into Southwestern the day before it opened. He was like on the wait list, and he was AOA, and the guy after him was not last to enter the class, and he was AOA. So the process of looking at experience, grades, and academic achievement is still not great. And I would ask that years ago, maybe 10 years, 15 years ago, did interviews for Southwestern. And I asked the head of the admissions committee, did they study their admissions? And he said no. And that really bothered me a lot. I said only when a student really fails out. And like that really bugged me. Not studying what you did. And like, so it's improvement in the admissions process is something, it's not easy. It's, that you have thousands of applications and you have, everybody looks the same. And like, it's hard. And maybe, so it's the picking of the students. The education, I think, is one thing, is like, it's much better in simulation. Simulation is good right now. However, like, you'll have a medical student and he'll have simulated four births or all that, but he will not have a live birth. And in the old days, they had 40 live births. They'd done 40, babies, the old guys. And so it's, the clinical experience is being diluted, but it's being supplemented by really pretty accurate. The simulation is good, but it's not the same as when, like if you like, and one recommendation I have to all doctors is keep a record of your cases. Because at some point in time, you're going to have a DNP said, I'm a doctor, and it's going to be your cases, not your degree. And so if you can say, I've taken care of 20,000 patients and here's the records, that's more compelling than the non-MD doctor who says, I'm a master's degree. Well, how many patients? And they've got 200. 20,000, 200, forget about the degree, forget about it. It's like, I'll take the 20,000. So that's one other thing. So I think that one thing in medical school is learning yourself. And so you really, the one thing about medical school is picking the right specialty for you. And that happens pretty well, but occasionally it doesn't. And that's really, really sad. And, but it's picking the right, and like, it's, emergency medicine is sexy, but it's not for everybody. And somebody who is like a lot of young students like it. However, the lifestyle is weird. It's really weird. You're a nights, weekends, and holidays person. And we had a doctor whose wife was really unhappy, and he was unhappy because we had him on shifts, and like, he hadn't seen his wife in a couple of days. I mean, weeks, because he was on nights and she was on days. So he's asleep when she's awake, and he's awake when she's asleep. And so they live in the same place, but different time zones. So like, and you're a family, and you're not going to football games because you're working. So it's not, and so it's not for everybody. And like, there's the specialist versus a generalist, proceduralist not. And so you have to do what makes you, what rings your bell. And a little bit of me is like, you must not make a decision because of money. You must not, because that will be, I think the foundation of being a great doctor is loving what you do. And if you don't love what you do, sooner or later, you're not going to be very good at it, no matter how smart you are.
That's beautiful, Compton. That is so important.
So a little bit to me is like, I wish that all medical students make the right call. I'm also concerned about there being not enough residents, because last year there was like 1,300 residents that did not have a job, did not have a 1,300 medical student didn't have a job. So I say, in contrast to me, the pressure is a little more on you. It's a little more on you, and having a, like when I was a medical student, you could be last in your class and still an orthopedic surgeon. Can't do that now.
We have 1,800 applicants for our 26 emergency medicine spots. Dan Septum, family medicine guy, you may know him, professor, spoke to us last week, and he said they had 2,000 applicants for their 14 spots. It is so competitive. That's in family medicine. So
I think that's a system problem where they have to make some more residency. But I think that one of the things is that being able to compete with non-doctors is going to be real important, and keeping track of your caseload, I think, is that. I mean, it's just my opinion, but it's to be able to document your experience, because the medical education in the United States is really good. And I mean, like my frame of reference is back in the old days, people would go from Southwestern as R3 emergency medicine residents to New Zealand, and they're like junior attendings, and they are much younger than the New Zealand attendings. And it's kind of like, wow. And the reason is because they had tons of experience. That they were chronologically younger, but experientially much older. And so the American, there's a lot of, American medical education is very good. And the reason it's good because it's experiential. It's based upon the patients. It's based upon that. It's not what you learn in a lecture. It's not what you were told. It's patient by patient, and that gives you real wisdom.
Compton, I think we have one more for you, and then we're going to let you go. Taylor, you see this?
Yes, I do. So how important do you believe it is for physicians to have outlets like exercising, gardening, music, just to keep them mentally and emotionally sharp?
Oh, I think it's fabulous. I think it's one of those things where you have to do it. All those things make you a better doctor. They gardening, music, piano, running, lifting weights, all those enhance your ability, your medical ability. And so it's not good. It's not permissible. It is good.
Well, Compton Broders, you have been such an important figure in my life and in the lives of so many, many people. We will have probably 5,000 people, 5,000 pre-healthcare students that will watch this program when we post it online over the next few weeks. And each one of them will go see 100,000 patients in their lifetime. 5,000 times 100,000 is 500 million. Compton, tonight you touched 500 million lives. And our gratitude we can't even begin to thank you. I'm going to ask all the students to put "Thank you, Dr. Broders" into the chat so that you can see that. Type away, please. Let's have 150 people pop in a "Thank you, Dr. Broders." And Taylor, you want to give us a quick message about what that thing is up on the screen there?
So this is assessment 81. Just be sure to have it finished before next Tuesday's session at 6:59 p.m. Also, we're going to be posting in the chat the link to quiz 3 from the 3rd session that we ever had. So you guys can go back and redo that or take it if you never took it in the past.
And I would say also be looking out. Come in one of the next sessions coming up, we'll begin to try to feed you some questions from one of the previous lectures, so that you can have the opportunity to get some more online programs with virtual shadowing. We're going to be here. If you keep coming back, we're going to keep having rock stars like Compton Broders come and be with us. And Compton, we're so grateful. So on behalf of the whole working group for virtual shadowing, we want to thank you for coming this evening.